Okay. So first, I want to thank you very much for taking the time to chat with me and discuss endometriosis, given that this is Endometriosis Awareness Month. So first, I just want to dive right into some questions. So this is a little bit more about, can you help us understand what endometriosis is? So for those who may not be familiar, can you explain what it is and how it impacts patients beyond pain and infertility?
Yeah. So, I mean, for most patients, the most important thing is it is a condition that causes pretty significant pain, usually around the time of periods, but not always. Some patients can have pain outside the cycle, but classically around the time of period. Interestingly enough, not all patients with endometriosis do have pain, so some are not diagnosed until there's infertility concerns or they have, findings on an exam, something like that. But in general, it's mostly known as a period pain condition. And it is what I call a cellular disease or a tissue disease, meaning that the endometriosis are implants or growths of a tissue that is similar to a normal lining that typically builds up with the inside the uterus and sheds with the period. They're similar but not identical to those cells, and they're found in a place where they're not supposed to be. So those types of cells are only supposed to be found on the very inner lining of the uterus. In endometriosis, those cells are found outside the uterus where they're not supposed to be, and they can be found on the ovaries, they can be found on the tubes, on the lining of the pelvis, they can be found on the bowel, the bladder, diaphragm, appendix. I mean, name most places endometriosis has been found there.
Is it true? I thought I had read somewhere that they'd even found it up into brain tissue before. And they
It's got to be extremely rare, but it has been reported there.
and then what about in a female in utero? Is it true that that has been found even as early as in utero fetuses?
The only thing I'm aware of, I know way back many years ago, Dr. Redwine did a study where he was granted access to babies that were miscarried, stillborn, and as part of their autopsy or evaluation, he was granted access to some tissue samples from inside the pelvis of the fetus, and they did document endometriosis in roughly about 10 to 11%, which interestingly enough is spot on with the incidence in adults.
Okay, yeah, okay, that is interesting how correlative those two values are. Okay, so endometriosis is notoriously difficult to diagnose, and many patients go years without answers. In your experience, who should be evaluated for potential endometriosis, and what's the best way to determine if somebody has it?
So really, anybody who has, I mean, again, initially it comes back to, a patient who doesn't have pain or doesn't know anything's wrong is not going to know anything's wrong. So first off, any patient that has painful periods, I think it's worth considering the option or considering the possibility. It is in what we call the differential diagnosis, meaning there's a symptom, and these are all the possible causes and sources of that symptom. So painful periods has to be in the differential diagnosis or under consideration. One of the biggest red flags for endometriosis is a young patient who has period pain bad enough to miss school. Those patients are typically more likely to have endometriosis than not have endometriosis. So, lately, over the last 5, 10 years, there's been a huge push in the GYN community. A lot of it kind of pushed from the pharmaceutical industry that's trying to get their medicines out to, instead of using surgery to diagnose endometriosis, to just listen to the patients and make a clinical diagnosis. That really, the clinical diagnosis just helps raise suspicion. So you look at the history, look at the painful periods, missed school, interrupted work, activities, those sorts of things when the patient was younger, and that gives you a clue to say, you probably do have endometriosis, but we really don't know for sure.
So, what is the benefit of doing a clinical diagnosis versus a laparoscopic, or like in your office where you'll do a diagnostic ultrasound? If you're doing a clinical diagnosis, is there, okay, that was, let me have you answer that question.
So again, for me, clinical diagnosis is a misnomer. It basically is just endometriosis is now really high on my list of possibilities. So when we look at that differential diagnosis, listening to the patient's history, Clinical diagnosis, I think, is a misnomer because all it does is just raise that to the top of the possibility list. It doesn't give me the diagnosis for sure. But it's something that we have to consider, not only for the patient to consider, but for the doctor to consider. And then we use that to say, okay, what are our options for moving forward? I'm sure we'll get into that a little bit later. But once we raise the suspicion, it's up to the doctor to say, hey, we think you might have this. These are the things that we've got to be aware of, and these are the things that we can do to try to get more information about what it's doing or if it's there, or how bad it is. And that's what leads into the evaluation. Typically after the history is done, we move to a physical exam, pelvic exam, the normal exam that patients go through. But that exam has to be guided by the history that we've just collected. If a patient has significant bowel pain with their periods or blood in the stool around their periods, that exam really should include a rectal exam to see and feel, is there something going on in the lower bowel that could point toward endometriosis in the bowel. So we use, the previous step dictates what we do on the next step. And then from the physical exam and the history, that should guide whether or not we do any imaging. There are a lot of doctors around that use, really predominantly here in Utah, it's really MRI, but it has to be an MRI that's done a special way. Typical MRI for endometriosis, they need to use a kind of a contrast gel in the vaginal canal. They need to use contrast gel in the lower rectum. And that allows the MRI to be done to see if there's infiltration into those areas, between those areas in the wall of the bowel. They can tell whether or not and raise a suspicion of adhesions or connections just based on the tissue appearance, but it has to be done the right way, and it has to be read by a radiologist who's experienced with it. I've seen a number of MRIs that have come back either normal or way overcalled. And when I get the patient in the office and do my dynamic ultrasound, it's completely different results. I am a huge proponent of dynamic ultrasound. Number one, I can do it at the visit. So it's not like the patient's coming in, we're gathering the history, we're doing all this stuff and say, okay, now I'm going to give you an order for an MRI. We send that out. We have to get an authorization from insurance. Once that comes in, the patient has to go in and get the MRI. Then we have to wait for the radiologist to read it, and then we get the report back. And then we bring the patient back in to go over the results. Whereas dynamic ultrasound, where I'm doing it, we do our history, we do our exam, we move right into the ultrasound, we turn the screen so the patient can see exactly what I'm seeing at the time I'm seeing it. And then we can use that as we move in the discussion to say, hey, this is what I think going on. I do think you have endo, but it doesn't look too bad, probably stage 1 to stage 2. Or you really probably do have endometriosis and there are signs that there's bowel involvement and things are stuck together. Ultrasound, in my view, is far superior than MRI at looking at adhesion connections between the tissues. Just because we're looking at that in real time, we're looking at movement of the organs rather than an MRI that is just looking for signs of connections.
I love that. And also, one, is probably more cost effective. It's
Oh,
clearly
huge.
more time effective. But then also, isn't it true then there would be a significant reduction in the amount of radiation that that person is exposed to? Or
Yeah,
is it,
MRI is more magnetic though.
oh, so it's CTs that are going to
Yeah,
be more radiation,
yeah.
MRIs. Okay, so that you don't
Yeah,
have
CT, between MRI, CT, and ultrasound for endometriosis, CT is the worst of the three.
Mm,
Rarely helpful.
okay. And then in terms of you have been doing dynamic ultrasounds for how long?
I started to get into it when I was in Ogden, probably around 2015, 2016.
Okay.
That it was in its infancy then. I just started to hear about it, and I actually ended up just pulling up a YouTube series from a sonographer in Australia that she posted her whole series on how she evaluates. And so I just figured, what, I'm doing the ultrasounds on the patients anyway, looking for, ovarian cysts and how the uterus looks. Well, I've just talked to the patient and say, hey, I'd like to do this. I'm not going to charge you for what we're doing while I'm learning this. And I would just see what I could see. And then I would make those notes and then I would take it into surgery and compare the two to see how accurate we could get. And it's remarkable. In studies now, there's a lot of studies that are published related to the ultrasound now. It's known as the ultrasound-based endometriosis scoring system. And we can accurately stage endometriosis with ultrasound over greater than 90% of the time, or with 90% accuracy.
Okay, that's amazing. And is there
Yeah.
any sort of standardization? Because I have heard previously, and it sounds like in the last 10 years, this has changed significantly, that there is an incidence of false negatives where
Yeah.
somebody could have it, but maybe the person doing the procedure isn't trained enough. And so having it in your office, you're not having an ultrasound tech do it, then being read by somebody else, then being sent to you. You are both doing the procedure and
Yeah.
reading the results in real time. Do you find that you get better results because of that as compared to another way of it happening?
I really don't have anything to compare it to.
You just
I know that, the studies are published. The biggest group, well, one of the most well-known, well published groups is out of Toronto, Matthew Leonardi's group. And I think they do use a lot of sonographers, but they're very well trained, very well trained. But here locally, I just don't have anything to compare it to. The only place that I think I'm even aware of doing dynamic ultrasound other than me is maybe the U of U's program.
okay.
Everybody else pretty much relies on MRI.
Gotcha. Thank you. That's extremely insightful and so valuable for people who are maybe not necessarily deeply into the medical system,
Yeah.
determining, know they've missed work, they know they've missed school, and they don't have a diagnosis. Maybe they've been told clinically. And so for those that are getting that clinical diagnosis, so again, to that top of that differential
Yeah.
diagnosis, are they then maybe getting some treatment, even though it's just a clinical diagnosis? Is that happening around town, or is what are you?
Yeah, and treatment wise, again, most of them, they make the clinical diagnosis and they put them on hormones, whether it's birth control, progesterones, or they go to the ones that put them into menopause. Really, without knowing for sure, that's what we're dealing with. Um, in those situations, for me, the benefit of the ultrasound is, let's say we have a patient in the early 20s, and most patients, not all, most patients are concerned with two main issues. The first is the pain and how they feel and how it's affecting their life. The second is concerned about fertility in the future. And patients who have a suspicion of endometriosis, if they choose to just, deal with it, not really do anything, or if they choose to go on hormones or their doctors put them on hormones, there still is the possibility of progression of disease. And at the time they start those medicines, we really have, unless you look, you really have no idea what state the disease is at the time you're starting treatment. But if a patient comes in with an endometriosis on that differential diagnosis, early 20s, say, and we do the ultrasound in the office, and let's say that everything looks clean, there's no masses in the bowel, the ovaries move well, the bowel moves against the uterus well, and it really looks like, there's probably endometriosis there based on your history, but it looks like it's a stage 1 to stage 2. I think it's fine for those patients to choose to stay on whatever treatment they're on. And if it's getting them where they want to be, if they're functional, I think it's safe to stick with that if they choose to do so. And then we can bring them back every year or two and repeat the ultrasound so that we can do surveillance. What I hated to see before we had the ultrasound is there was no way to track it. So we would have patients on hormone or choosing to be on hormone, and then we'd get 5 years down the road and find out that it has become destructive. And it would sneak up on us. With using the ultrasound for surveillance, it's really not going to sneak up on us. If it starts to change, we will pick that up earlier than just kind of sitting and waiting. That to me, that's the benefit for younger patients. And then others, we might see just some early adhesions of the ovary. That gives us at least an idea that, hey, there's some inflammatory aspect to your endometriosis that's more advanced maybe than what we see at their age. And then it gives them information to consider as they look at continuing palliation or symptom control versus, hey, is now the time to go in and get it taken care of before it has a chance to get advanced.
That's fantastic. And that leads us into the next part of this, which we're sort of alluding to, but we haven't specifically said, which is informed consent with endometriosis treatment. And so, how do you approach? Because I know this is a big part of your practice, and I
Yep.
think that this should be the quote standard of care, not just for endometriosis, but for
Yeah.
all healthcare decisions. But how do you approach informed consent when discussing options like birth control, hormone suppression, or excision surgery?
Yeah. So, I mean, you mentioned standard of care, and you said it should be standard of care. True and complete informed consent is standard of care. It is standard of care. And the reality is that for endometriosis, doctors are completely failing informed consent for the most part. As patients listen to this or people listen to this, how many times have you gone into your doctor's office, had painful periods, that, oh, you might have, it's either normal or you might have endometriosis. Here, take this pill. And the doctor makes the decision for the patient without giving any other options, and even without discussing the risks of the birth control pill, the risks of not treating the disease. There's none of that discussed. It's the doctor listening and saying, hey, you probably have this. Here's a pill to take. That is not informed consent. So much more or so much is left out that patients need to know as they look at their options. So the way I approach it, even in a teen patient, teens are patients too, and teens have endometriosis affects their ability to function as teenagers. It has the potential of risking fertility down the road. So a teen patient gets the same discussion as an older patient. And we go through the same things based on your history, based on the exam. I think you're more likely to have endometriosis than not have endometriosis, or we have a previous diagnosis from a surgery. And then we go through typically 3 categories of options. And every patient with endometriosis has these 3 categories of options. The first is to not do anything. I tell them, the first is really to just kind of suck it up and deal with it and understand that it's probably there, but you're choosing not to do anything about it or worry about it. And that's an option. It's not a very popular option, but it's an option. And the second is what I call palliation or symptom control. And in that category, I mean, there's a lot of different things that go into into the symptom control. The common ones in the medical world: birth control pills, progesterone pills, IUDs, the medicines that put you into menopause, Lupron or Lissa. The interesting thing is, head to head, all of those medicines, for the most part, they work about the same. So one is not proven any better than the other. Head to head, Lupron was no better than birth control pills. It was no better than the progesterone IUD. There was one study comparing Orlissa to the Depo-Provera shot, and from a pain response, it was no better than the Depo-Provera shot. So they are meant to control symptoms. There is no evidence that they prevent progression of disease. And, informed consent needs to be truthful. And that is an untruth that is often told to patients, because they're told, I'm going to put you on this medicine to prevent progression of the disease. Or they say, we're going to put you on this medicine to suppress the disease, but nobody ever defines suppression. Suppression most likely means, I think there is a role in hormones of controlling the inflammatory side of endometriosis to a certain degree. But there is no evidence that any of those medicines prevent progression of it. And that's important for patients to know. Even if symptoms are completely controlled, they have to be aware that if I'm on this for 5 years, I could get to my late 20s and find out that the endometriosis has completely taken over and destroyed my dreams of a family. Within that realm, we talk about, physical therapy to treat kind of the adjunct pain triggers from pelvic floor spasms, contractions, myalgia, we call it. We talk about acupuncture, acupressure, dietary changes, supplements, turmeric, magnesium, omega-3s. We bring all of that into the symptom control. Serapeptase is one that's kind of creeping up in conversations more. As far as we know, again, that kind of fills that palliative or symptom control role. And then the third category is surgical. And every patient has an option of surgery, whether they're 15 or whether they're 45 or older. Surgery is an option for every patient, whether the disease is early disease or whether the disease is stage 4 with bowel involvement, frozen pelvis, everything stuck together. Even surgery is an option for most patients, the huge majority of patients. Now, when we see patients with advanced disease, often their doctor either knows ahead of time, or that they get in and they do what's called a peek and shriek. So they haven't done their ultrasound to triage and try to get an idea how bad the disease is before they go in. So the doctor gets the camera in and realizes, wow, this is bad. Everything is scarred, and they kind of mess around for a little bit, take some pictures and get out. And then they tell them your only option is birth control or hysterectomy. Not true. An informed consent is not limited by the treatments a particular provider can offer.
That's
And
a
that's important to
really
know.
powerful statement.
Yeah.
So then how does somebody find the right provider? How does somebody come into your world?
Um, Slowly, we're starting to get some referrals. More often than not, it's patients getting frustrated with how things are going and doing research on their own.
What are
Uh,
you finding in terms of the typical time that somebody has maybe gone with option one of doing nothing, option two, and maybe the doctor chose, maybe they got informed consent and still chose that, whatever route option two was. How long is that before they come to you? And how many of those have also had a prior surgery, say maybe an ablation versus an excision?
Um, uh, Honestly, time frame, I really don't have a good idea. I mean, the only real time frame that we have is, in general, it takes a patient from onset of symptoms to diagnosis somewhere between 8 to 10 years.
Yeah.
But I don't know a specific timeline of how long they've dealt with it versus, hey, but most patients too see somewhere between 5 and 8 providers before they're given a diagnosis.
Yep. Yep.
So that throws some clarity into
So
it. But,
5 to 8
time frame
providers,
from, dude, yeah,
years. So
yeah,
really, really long time, lots of suffering, maybe
yeah.
with some interventions that were palliative, as you say, and maybe some that were not, unclear if they've been monitoring disease progression or if it's just been that clinical diagnosis. Um, Okay, this was incredible information so far. And if you could lay out your perfect recommendation, is it really independent or dependent on each person's presentation? Like if you had your druthers, would you say that if somebody was, like you had mentioned, stage one and stage two, they choose option one, they choose option two in terms of suck it up, do some PT, some supplementation, maybe birth control or something else in that realm. And then we monitor disease progression every year and then decide on if surgery is appropriate if it continues to progress. I guess paint me a picture of,
I mean, I do not get involved in that decision. I feel my role is an educator. My role is to help them understand what is going on, how bad we think it is, or how bad we don't think it is.
yeah,
Present the options to them with the pros and cons, and then let them decide.
right.
I am full on for endometriosis care. I am full on board with patient autonomy in making that decision. That is not my role.
And it probably comes
That's the way I approach it.
And that makes sense because there could be somebody with stage one endometriosis that has a very impaired quality of life. And there could
Yeah,
be somebody with a stage four endometriosis, has probably had the disease for a significant
yeah,
period of time and is now struggling with fertility issues
yeah,
and now wants to do something about it, even though they weren't necessarily diagnosed or
yeah,
incredibly symptomatic or enough that it impaired their quality of life.
yeah,
So maybe
yeah.
it
And
comes,
that is not my role because I'm not the one living it.
yeah. Okay. So you just give as many choices as possible
Yep,
and let that person make the decision that's right for them. Yep.
yep,
Makes sense. Okay, so best practices in excision surgery and your clinic. So, can you explain excision surgery versus ablation and why they are so different?
yeah. So first, for ablation, important to clarify, there's another procedure called endometrial ablation that is used for heavy periods. It's where they go in and kind of use a heat energy to destroy those normal lining cells of the uterus that they go in. And anytime we use heat to destroy cells, it's an ablation.
Okay.
So that's completely different. For heavy bleeding, treating those cells inside the uterus, completely different ablation scenario. For endometriosis, we treat that laparoscopically. I am a firm believer that you cannot adequately treat endometriosis through a big open incision, what we call laparotomy. You just can't see it. I mean, the doctor's looking through this incision on the belly. The view is clear down here. You're looking into a place that's not very well lit for microscopic lesions. You just can't do it. So laparoscopy. At laparoscopy, we use that camera to help identify the areas that are involved and then some form of treatment. Most doctors use what's called an ablation or laser vaporization, where they use a heat source or they use laser to try and destroy the lesions of endometriosis. Just yesterday, I think I posted one on my Instagram page and Facebook page showing an area. If there's a scattered area of endometriosis lesions, most of them will burn across the surface or laser across the surface. But often the doctors really don't know how deep that disease goes. And if you don't touch it, if you don't pick it up, if you don't move it around, you miss deep disease. If you don't know what deep disease looks like, if all you're looking for is the classic appearance of endometriosis, whether it's the blue-black, blistery kind of blood-filled lesions, the red lesions, the blisters, if that's all you're looking for, you're missing some of the most significant endometriosis that's there. The deep fibrotic extensive stuff that wraps around nerves and causes pain symptoms, that causes adhesions. If I go all the time, I see reports where there were adhesions here, so I separated them, but the doctor didn't step back and think, why are those adhesions even there? They're there for a reason because it's not normal for things to be stuck together. So if they separate the adhesions, but they don't go after the tissue that caused the adhesions, they're not treating the endo. And then if they use an ablation technique, again, that is very superficial. I guess, in theory, if there's some endometriosis on the side of the pelvis, there's nothing important behind there. So there's no ureters, there's no bladder, there's no bowel. Technically they could burn high enough and long enough to completely destroy that lesion. But the longer the heat is applied, the deeper the heat goes, the deeper the damage goes and the destruction goes. So if you do that on the bowel, you're going to be burning and destroying the bowel or the bladder. You're going to be hurting things and doing damage. Most doctors don't even come close to burning. If there's a deep lesion, they're just brushing across the surface. And I tell patients it's like trying to melt an iceberg with a blow dryer. That again, if you don't touch the tissue, don't pick it up, don't move it, you have no idea how deep that nodule goes. And the deep stuff, really anything deeper than a millimeter or two cannot be treated by ablation. It's just not safe to apply the energy that long enough to just fully destroy the lesion. And if you do, it causes heat damage to the surrounding tissue as well. So with excision, the idea is just how a dermatologist would attack a mole. The goal of that is to identify the problem areas, get all the way around them, get all the way under them, completely removing the tissue down to normal tissue levels. That's always the goal. Do we achieve that in every case? No, but that's always the goal going in.
Seems to me it's almost analogous as well to removing a cancerous lesion, right? You
Yeah,
won't remove, say, a cancerous mole and leave part of that there because then it's going to continue to grow. And it sounds
yeah,
like we're just burning without knowing the depth of that endometrial lesion, then it's going to continue to spread,
yeah.
correct?
Yeah, and in certain cases comparing cancers, I would never say endometriosis is as critical as cancer, but some patients certainly feel that. But in many cancers, the approach to surgery is to do what we call debulking, to remove as much of the cancer as we can, but understanding that we're not going to remove it all because then we'll come in and chase it with chemotherapy. Medicines that are they're really hard, but they're meant to actually kill the cells. We do not have anything like that for endometriosis. So the goal for endometriosis surgery, if the patient is okay with it, needs to be complete excision of the lesions and the diseased tissue.
And with a complete excision, I mean, obviously your goal is to get rid of all lesions that you can find. If that occurs, does that mean they're in remission? Does that mean they're cured? Does that mean the disease won't progress?
Um, so short answer is we don't know. We don't know the full answer to any of those questions. I'll lead off with that. I do think going in and getting the endometriosis removed, it is very unlikely that disease will ever have a chance to progress. The patients that I've gone back in on either, second time from a surgery with me or with another endometriosis doctors that I know and do good surgery, it is very, very uncommon to go back on a second look and find it anywhere close to what it was the first time. It can happen, but it's rare. The true answer to recurrence, we don't, for some reason, we don't use the cure word in endometriosis. Reality is we don't know. There may very well be patients that have been cured, certainly patients that never have to deal with it anymore. Deal with the symptoms and they just move on. We do get those patients. But it's an effective cure. We don't know if they're cured because they've never had another surgery to go back in and look for it.
Right.
But true recurrence rates, I'm not aware that study has ever been done, where they've taken, say, 100 patients, 500 patients, done surgery, excised the disease, got pathology on it, and then either 2 years later, 5 years later, 10 years later, take them all back to the OR, take samples, take tissue, compare it, who's positive, who's not positive. I don't think that study's ever been done. So true recurrence rates, I don't think we have. But there are a couple really good studies done. One is an older study with Dr. Redwine, and then one is it was published last year, big study by Dr. Roman in Europe that really showed, I think, a lifetime recurrent or lifetime repeat surgery rate of 28%. I think a 10-year recurrent surgery rate of less than 20%. My data is not published data, but when I reviewed my data when I was in Ogden, we had an 11-year period where I had access to the system and I could see patients, local patients who had surgery with me, or if they went to another doctor within the local system. And that repeat surgery rate was around 11%. So I just tell patients now, repeat surgery rate realistically probably less than 20% chance of that. So 80% chance that they'll never need another surgery. It's not the perfect marker, but it's a pretty important one.
Huge. And for you to have unpublished data, but data nevertheless that demonstrates 11% over a long period of time, that's incredible.
Yeah,
And
and those ones that do go back for another surgery, at least in that the study by Horace Roman, the most common reason for going back for that second surgery was for hysterectomy. It wasn't even for endometriosis.
so was it more for adenomyosis?
Yeah, or continued peripain, adenomyosis type stuff, bleeding type things.
Gotcha. Okay, so I should have asked this question earlier on, but can we speak to what causes endometriosis? It's not quite an autoimmune disease.
Yeah,
There is the theory from the 1920s where it was thought to be from retrograde menstruation. Can you give us just
yeah,
current data on where it comes from? Why does 10, 11% of women develop it? Yeah, speak to that.
yeah. So I think the most likely source, and again, I think with a caveat that the more we learn about endometriosis, if we ever get the chance to, I think that endometriosis is going to be a spectrum of diseases because it presents so differently. We have superficial endometriosis, we have deep endometriosis, we have some endometriosis I get in there, and it is just completely proliferative. It looks like a growing endometrial lining. Those are fairly rare, but I think it's going to be a variation on a theme with a whole bunch of different, potential diseases wrapped up into one diagnosis. I am more along the lines of this is a disease that is born uh, by cells that are deposited in the wrong places during fetal development. And again, that kind of goes along with the idea of that study with Dr. Redwine, and it's just funny that the incidence in the fetal incidence is about 10, 11%, just like the adult incidence. That's remarkable to me. So one theory is that the cells are deposited in the wrong place during development, and then as hormones become active and the tissue becomes active, it starts to become inflammatory and the symptoms start to creep up. Um, the retrograde menstruation or backflow, we know that happens. It's been documented. We don't know if there's a direct correlation to the formation of endometriosis implants. Years ago at one of our international meetings, Michigan State, they have a lab up there. I believe it's baboons that they use, but they actually took menstrual cells and laparoscopically placed them in the pelvis and went back and then diagnosed endometriosis. But again, that's kind of it's an artificial model. Um, the interest, there's so much that points away from retrograde menstruation when we look at surgical treatment and outcomes. We mentioned, we talked about second look laparoscopies after an excision. It is extremely unusual to find new endometriosis in areas that have been previously excised. And one would think that if it were purely retrograde menstruation, that there would be a very, very high recurrence rate in those areas. And we just don't see it. Um, there's a lot of nuance to this because we think that there's probably the potential for hematologic spread, meaning that cells get in the bloodstream and are deposited or left in other places. That's kind of the remote areas, lymphatic spread. It has been seen in lymph nodes. I've had a few patients over the years where we've had lymph nodes come up positive for endometriosis. I think the majority of these cases are cases where the cells are deposited in the wrong place during fetal development.
Okay, thank you. That's great information.
Okay, can I bring something else? You know, the whole discussion with retrograde menstruation. You know, you talk to the general OBGYN community and they come up with, you know, the definitive treatment for endometriosis is going to be hysterectomy. You know, that gets rid of the period so that the endometriosis can't come back or whatever. It's like, you know, why, if you firmly believe that endometriosis is caused by retrograde menstruation, why don't you just do a tubal? I mean, that's a 15-minute, go home the same day, quick, you know, no significant bleeding risk from hysterectomy is a much bigger surgery. But I mean, if you firmly believe that it's retrograde menstruation, why not just do a tubal?
Great point.
Yeah.
My only thing that I would counter, and not because I want to play the devil's advocate, because I just loved what you said, and I feel like it should just be a mic drop and walk away. But I wonder if it's because of pain or suspicion of pain. But I'm a huge fan of not doing a hysterectomy.
Yeah. But, you know, and again, certainly there are other pain generators with, you know, pelvic floor and adenomyosis and a tube, you know, tubal's not going to do that. But, you know, purely speaking, endometriosis, a tubal's a much easier surgery to recover from than a hysterectomy.
First time I've ever heard somebody say that, and it makes so much sense. So thank you for sharing that insight. How do you currently, so I'm going to pivot, since I am a pelvic floor physical
Yep.
therapist, just love to ask, how do you incorporate pelvic floor physical therapy into your treatment, both pre-operatively and post-operatively, to optimize patient outcomes?
So I am one that you're probably not terribly happy with for the pre part. And I get, you know, and I've talked with a number of physical therapists about this before, and I don't know the nuance of, you know, getting the patient accustomed to the physical therapy and getting some response. My worry has always been, you know, send patients to pelvic floor physical therapy before surgery. They make progress on that physical therapy, and then I go screw it all up with surgery, and they're right back where they were before. So you're probably going to have to educate me a little bit better about the benefits of pre-surgical PT. But that's always been my worry. Is it worries me that they'll go through all of this, you know, the time and the expense of this, and then surgery is going to put them right back where they were in the beginning. That's my worry. Post-operative, honestly, I like patients to, you know, unless I know that during my physical exam in the office, I check for that. Certainly, I'm not as good as what an experienced pelvic PT is. But I do evaluate the muscles. And again, I do a lot of comparison to what's normal versus abnormal. And if I find tight muscles, we talk about that. Say, hey, we can do the surgery, this and that, but muscular pain may be something that we need to deal with. But I do like them after surgery to give them time to recover and then see where they're at. Because if they're not having issues, why do the PT? If there are still issues, then we know, you know, from the preoperative exam that this is a thing, and we start working toward that and continue the physical therapy. So that's the way that I've approached it. I know it may not be the most popular approach, but that's the way I've been doing it.
Perfect. And I think this gives us a good opportunity to have a conversation about it. So, you know, I can go back and do another literature search. We do know that physical therapy preoperatively, in particular to orthopedic surgeries, it's clear cut. It's so clear that if we can get in and we can improve the strength and the coordination and the motor control, so that connection from brain to body, whether that's the core, whether that's the pelvic floor, whether those secondary hip, glute, back muscles, that will carry over. We
Yeah.
do also know,
And
though,
maybe I've been focused too much on just, you know, focused on the pain side of things rather than the recovery side of things too, because it sounds like that would probably be helpful as they move into the recovery phase.
absolutely. And if somebody's, you know, and depending on where they're at in their journey, say early on, and you're like, here are your choices. And then with informed consent, they go, I don't even want to take birth control. I
Yeah.
definitely take Lupron. All right, give me the magnesium, give me
Yeah.
the, right, give me all of those things, send me to pelvic PT.
Yep.
And I will just say, I also do visceral mobilization. And I almost think it would be beautiful to see pelvic health therapists be pelvic abdominal therapists, because really to me, It should really go from the respiratory diaphragm down. And I view the
Yeah.
pelvis the center of the whole system.
Yeah.
So we know endometriosis can travel throughout the body. So
Yeah.
somebody could be having fascial tightness affecting their shoulder that connects down into their pelvic floor. So we're just looking at it from a more global,
Yeah.
systematic approach. But then if say they go, you know what, I want to do surgery, I want to do it right away. Well, then obviously do the
Yeah.
surgery. So depending on where they're at in
Yeah.
that,
And we talk about all that so that, yeah, they get all those options, and some will choose that route. Especially if on the exam I can feel some tightness in the muscles and some pain trigger in the muscles. There are patients who will focus on that side of things first.
yeah, for sure. And then
Completely appropriate.
post-operatively, and this is an older study, but it said that any time you have any form of abdominal surgery, whether it's open, whether it's laparoscopic, you can develop secondary adhesions related to the body's natural healing process. And so going in and doing both pelvic but also abdominal PT can be really helpful in making sure that we're helping with scar tissue
Yeah.
mobilization. Obviously, once they're healed, and as well that coordination between the pelvic floor and the abdomen and pressure management. We know anytime there's been,
Can I bring a question up?
please, absolutely.
So related to adhesions, typically adhesions form within the first 10 days after surgery. So PT, I mean, clearly PT is not going to happen that fast.
Nor should it,
Um,
right? We want to have
from
that.
deep visceral mobilization,
Mhm.
that is a technique really to try to help loosen or break up the adhesions that have formed.
No, because I think that really needs to happen surgically. I wouldn't say that with
Yeah.
visceral mobilization, we're doing anything to break up adhesions. I definitely think that
Yeah.
has to be done surgically. But I think if we can make sure that if we think about that sac, that parietal peritoneum that holds all the organs, and then that inner, that visceral peritoneum, if we can make sure that relationship is moving and sliding and gliding
Yeah.
well, along with those more superficial fascial layers,
Yeah.
I think somebody's going to have a lot less pain or restriction or like impaired muscle activity. And that's where
Yeah.
we end up seeing it. Like a rib will be more flared
Yeah.
or they'll have decreased muscle activation. But in terms of like truly getting adhesions, that's where it's going to be a
Yeah.
surgical solution.
I like your idea of really, carrying it beyond just the pelvic PT. Anytime there is a muscular insult or weakness or whatever it is, the body is going to compensate.
Exactly.
And when a patient is not able to use a muscle how it is supposed to be used, they're going to compensate with other things.
Yep.
And whether that translates to hip flexors, abdominals, diaphragm, rib cage, all that sort of stuff. It's all connected.
Absolutely.
And the compensation factor can really start to bring in a lot of distant discomfort that a lot of people will not put together.
So true. And there's the hip bones connected to the knee bone, that whole thing.
Yeah.
It's true for the whole body. We really are all connected. There's actually a really cool study where they looked at the brain under an fMRI, and in as little as 45 minutes, the sensory cortex portion of the brain can become smudged, meaning it can't discern where one finger is from another. And they took a subject and they taped two fingers together, and within 45 minutes, that sensory cortex was smudged and could no longer discern whether those people had 4 or 5 fingers. So we talk about doing a surgery, we talk about having chronic pain, anything like that can create that smudging of the sensory cortex,
Yeah.
and the body will start to compensate. So
Yeah. Yeah, that's the hard thing about the chronic pain too. The longer we know that got to get the word right. I think it's nociceptive is actually the painful insult. So if I touch a hot stove, that is a definite pain trigger.
Mhm.
If I have endometriosis, the early on, every time that endometriosis flares, it sends a pain signal from where the problem is. The longer that goes on, again, the muscular response to it, and pelvic PT and chronic pain, I tell patients it's kind of like throwing your back out. Most patients, if their back goes out, the pain that is lasting is not from the bones actually being out of position. It's the muscular reaction to try to stabilize the spine so that it can't get any worse. And in the pelvis, I think over time, the longer that painful insult is there, the more the muscles are recruited in to try to protect that patient from hurting. And the longer that painful insult is there, again, those nerves are constantly being triggered and firing. They come from the pelvic area, And those pain impulses are sent to the spinal cord, and then they're routed through the spinal cord and sent up to the brain. But the longer that painful insult is left in place, the more likely that spinal cord is to form a loop that we call central sensitization. So even if we go in and get rid of the painful insult, the nociceptive insult, there still is the possibility of that loop in the spinal cord continuing to trigger, so the brain thinks there's still disease there when there's not.
That is so clearly explained for people to hear.
Yeah.
And so that's where, as PTs, will also go in and do a lot of
Yep.
pain neuroscience education. And once somebody understands that there is no longer a threat, we've removed the threat, that can actually start to change that central
Yeah.
sensitization. But people having that understanding is incredibly
Yeah.
important.
And that all comes back to the delay in diagnosis too. Doctors leave these patients hurting for years. And not only are we leaving them at risk for progressive disease, we're leaving them at risk for central sensitization.
Absolutely.
Tough
Absolutely.
to treat.
Yep. Okay, so many patients with endometriosis struggle with pain during their menstrual cycle, aren't referred to PT. What do you think could change in the medical field to make pelvic PT more of a common part of endometriosis care? Do you feel like this conversation, much like our conversation in getting the awareness out for what you offer, like how do you think we can improve that awareness?
It's got to be in continuing education. And the thing is too, and I don't know for sure because I haven't seen numbers. Um, and you would probably have a better idea of this than I would, but I honestly see a pretty high number of patients where, their doctors basically they come in for a pain consult and physical therapy is an automatic part of what they send them to. So like even before considering surgery, even before anything like that, even without even doing an exam to see if there's pelvic muscle tightness, they knee-jerk send them to physical therapy. I see that a lot. I don't know if that's something that apparently it's not something that you have noticed.
Nope. I
So yeah, I
find
mean, really that needs to come in, in grand rounds, continuing medical education type of stuff, of bringing that into the idea that again, whatever the painful condition is, the longer that painful condition is there, the more likely that there is to be a muscular component to it.
I have a patient that I only see once in a blue moon now for just occasional maintenance care, who is exactly the person you described earlier. She saw, I think, 7 providers over the course of 12 years. And at that point, 12 years into it, it was the first time anybody had ever recommended pelvic PT.
Wow.
And we reduced her pain. Her main complaint was pain with intercourse, and we reduced it by
Yeah.
98% within 2 visits.
I mean, we can't even get that good with surgery for the most part.
Yeah,
That's awesome.
was she all better? No, like she has
Yeah.
some conditions,
But
and
yeah.
being one. But if we can improve somebody's quality of life and we can do it rather quickly now, not everybody is that fast. I wish
Yeah.
if everybody was that fast,
Oh,
then
I tell them all that PT is a good option, but it is not a quick. I say it's very effective, but it is not a quick answer.
correct. And for most, yes, and I would agree. That patient was exceptional. And others, again, if the longer they're in pain, typically the longer it's going to take to
Yeah.
get back out of pain due to that central sensitization and all of the other sequelae of compensation. Okay, so that's interesting. So we're on 2 different lenses and we both have different perspectives. And it sounds like I feel like people wait too long to get into pelvic PT, and you feel like people are waiting too long to get into CU. So hopefully this
Yeah.
conversation will be good for people to understand there's benefits in both, and it's not a one or the
Yeah.
other. They're very
Exactly.
much complementary to one another.
More and more, for when we look at patients with endometriosis, more and more, they're starting to be treated as patients with pelvic pain. Endometriosis consideration and care needs to be part of that. Pelvic physical therapy needs to be part of that. Decreasing sensitization needs to be part of that. That's where really the multifactorial, multidisciplinary view of things comes into play. I'm very heavily, yeah, at least my practice, it focuses on the surgical treatment of endo. There are doctors and programs in the area who are very, very experienced on the medical, medical treatment, central sensitization and trying to decrease pain with varying techniques and modalities. That's not my forte, but we're fortunate enough to have really good ones in the area that do work with that. And then, we got physical therapists. When I was first in Ogden, there may have been 2 or 3 physical therapists that I was aware of in the area. And we're getting very, very lucky because more and more we're getting some really good, qualified, experienced, helpful physical therapists in our area.
Yeah, I agree. And I think the more qualified pelvic PTs there are out there and the more awareness there are, the more people are not going to have to
Yep,
walk around suffering with chronic
yep,
pain. Yeah,
yep.
absolutely. Thank you for this. Is there anything else that you would want to share with the public about endometriosis or endometrial treatment, endometriosis treatment rather?
I don't know. I mean, we've covered kind of the ones that I focus on a lot. We've talked about the informed consent. I really think, doctors can argue back and forth about studies on what's the best way to approach it, surgery, ablation versus excision, or surgery versus medical management, all this sort of stuff. But nobody can argue that a patient should not have an informed consent. And that is not happening to a great degree. And that is ethically not right. To me, it's probably the biggest problem in endometriosis care currently. Others would say it's the delay in diagnosis, all that sort of stuff. But the delay in diagnosis comes from not having an honest discussion with the patient about what they think is going on and what the potential treatment options are. Even in patients where we just think, hey, you have painful periods. I don't know if it's endo, but it could be. They still need to be presented all those options. And one of the benefits of surgery, let's say imaging is all normal. One of the benefits of surgery that a patient should be aware of is that we can make a diagnosis. We can give them answers. Although I am a firm believer there's like zero value in just a diagnostic laparoscopy. If I as a doctor go in and I put the camera in and say, yeah, you have endo, let's go back and put you on all these hormones that haven't worked for the last 5 years. There's no value in that at all. But patients really should be given an option. And this whole idea that hysterectomy is definitive treatment for endometriosis. There's a line from The Princess Bride where he says, I do not think you know what that word means. I'm not sure doctors know what the word definitive means if they're using it to say hysterectomy is definitive for endometriosis. I mean, common sense tells us that endometriosis is a disease that occurs outside the uterus. There's nothing that says removing the uterus, removing the ovaries magically makes endometriosis go away. I mentioned in the beginning when talking about what endo is that it is a tissue disease. It is a cellular disease. And those cells and those tissues are going to be there unless they're either cut out or we have a medicine that kills the cells off and makes them go away. And removing a normal uterus, removing normal ovaries does not make that endometriosis go away. And some of the deeper implants or more aggressive endometriosis does have some enzyme activity that can locally produce its own estrogen supply. So those are all things that are important for patients to know. And then again, we would love every patient that has endometriosis surgery to be 100% better. But we all know that we don't achieve that. But that's where we really have to bring in some of these ancillary, things in like the physical therapy to utilize the physical therapists and really do everything we can to try to help patients get a better quality of life when they're still struggling. Most of those things outside the hormones in that palliative category, whether it's PT, whether it's dietary changes, acupuncture, acupressure, those are all things that they help some patients. They don't help all patients, but there's like no risk or very low risk to any of those.
Yeah.
So there's very little harm and risk in trying those things. And if you get some benefit from it, great. We will take that any day of the week.
Yep. Perfect. Dr. Arrington, thank you so much for your time today. Where can people find you? How can people reach out and make an appointment to see you if they have suspicion of endometriosis, are interested in having a real-time ultrasound, in having a really true informed consent conversation to determine what choices they can make for themselves?
Yeah. The easiest one right off the bat is endowest.net, N-E-T, on the internet. Uh, I'm on Instagram, on Facebook. One of them is like Jeff Arrington, endosurgeon. I think both of them are some variants of that. We do have an EndoWest Instagram page as well. Um, Phone number, I get 801-433-2190. We offer certainly in-office visits. I do offer the dynamic ultrasound as a standalone service for patients that want it. And that ultrasound, patients worry about the cost. I don't contract with insurances. That's a topic for another discussion that I've addressed on the website and in some other webinars. But my ultrasound is set probably $600 lower than most ultrasounds that are not near the quality. Those are just basic ultrasounds done at a hospital or another practice. Mine is the dynamic ultrasound. The fee for that is set really low, I think, and just gives incredible information for patients. So that's option as well. We do free record reviews. We have a site on our website where patients can register for a free record review. Gives us a chance for me to look through all their history and then have a phone conversation, just to help give information. I have always approached this, if I can review a patient's records, and, if they're remote or if they have another established doctor who they really like, and I look at all their stuff and say, hey, I really think that this probably endo may be a little bit lower on the list. Maybe hysterectomy is in order. If I really think that their symptoms could be treated just by hysterectomy with their local provider, I'll tell them that. I don't want to force them to come and see me. If I know of a provider, a good provider, for out-of-state patients, somebody that's closer to home, somebody that would be more logistically easier for them, I will share that with them any day of the week. I want it to be easier for patients, want them to get the care that they need, and provide the level of care that I can. I'm happy to take care of anybody that wants to come, whether it's just guidance, whether it's information, whether it's treatment, whatever I can do to help.
Thank you. That's wonderful. That is massive value for people, all that you're offering, either the standalone dynamic ultrasound, the medical record review, the consultation, all of that. That's top notch. Dr. Arrington, seriously, thank you so much for all of the time that you've graciously shared with us today. And we will put links in below so people can contact you and locate you easily.
Awesome. And thanks for your patience and persistence.
Hey, I think you do amazing work, and I think everybody needs to know about it. So thank
Awesome.
you. All
Okay,
right,
very good.
take care.
Bye.